a 21-year-old male who came with alert history of snake bite 30 minutes back over his right ankle. Snake identified as venomous Cori viper. So that is the only information that we have with you. On initial examination, airway is patent, breathing, spirit rate of 30 per minute, saturation of 98% on room air, single breath count. That's what I told you in the morning. You ask the patient to take a deep breath, 1, 2, 3, 4, 5, and ask them to count till 30. So usually you will be able to do that. A single breath count is 30. Circulation, the heart rate is 110 per minute, BP of 130 by 90, and disability of GCs of 15 by 15. So grossly, except for some amount of tachycardia and tachypnea, he looks okay. So he had an envenomation 30 minutes back and he has completed. Okay. So somebody has done some first aid which should not have been done. And so that is the thing that you commonly see. So majority of the time you will see a patient with a total care. So now the question arises, what do you do to be done next? What will be your next step?
In the case shown that the patient is anxious.
Okay. Okay, reassure. What will you reassure? Okay, you have been bitten by a snake, don't worry. What do you say? Okay, yeah, it's available. Okay. You reassured the victim. Okay, fine. That part, the first, except for the tourniquet, every part has been done to him. So there is a tourniquet in place. What will you do? Slowly. How will you slowly do this? You show me how to slowly do this. Untie it. Once you untie it, it is already untied. No? The pressure is released. So again, the problem about dynamo in our mind, the problem with the tourniquet. The problem with the tourniquet, what is distal vascularity, blood supply is cut off. And the edema that is developing, we are not very sure whether it is due to the tourniquet or whether it is due to the bite. So it has been 30 minutes, unlikely that a swelling could have happened due to the bite. So what you need to do, you need to remove this. There is no doubt in our mind. Remove it. Now the question comes is how to remove it. So how to remove it? The problem that you think theoretically is that when you suddenly release the tourniquet, there can be sudden gush of venom and the patient can deteriorate. That is all theoretical. Okay. It is theoretical, but we still have doubt in our mind. If the patient suddenly deteriorates, they start putting the you remove the tourniquet, and because of that, the patient is deteriorating. So instead of that, what we can do, just apply a BP cuff above this. I said the systolic BP is 130/80 for this patient. Just keep at the level of the systolic blood pressure, 130/140. You keep that raised, the cuff, BP cuff, and you stabilize it there, and then you release the tourniquet. Then what you do, then you slowly release the pressure over a period of time, maybe in the next 2 to 3 minutes. So by the time, at least in your mind you are satisfied, you have not helped the venom to gush into the blood very quickly. So that is only method, there is no evidence for this. There is only one consensus that what we have come up across when we had discussion on this. So in order to avoid that confusion in our mind, this is one technique what we can do. So that is regarding tourniquet. Okay. So the next thing what you need to do, this patient. So he's 30-year-old male, he is saying that he has been bitten by a snake, probably viper. He is not very sure it is a viper or not, probably viper. Are you able to appreciate any local reactions in this patient? Any fan marks or anything? A fan mark doesn't have got anything to do with whether it is a venomous or a non-venomous. Venomous snake can have fangs, non-venomous snakes also can have fangs. So that is not going to give you a clue whether there is any features of envenomation is there or not. So what you should do next? You do a proper examination, do the lymphadenopathy assessment. Whether there is any lymphadenopathy, then the whole picture changes. If there is lymphadenopathy, yes, you need to give anti-snake venom. So that is one of the indication to start your anti-snake venom. So you have localized lymphadenopathy with a bite history on that limb, you need to give your anti-snake venom. So the next question, what is the next investigation that you want to do? What you learned in the last session? 20 minutes WBCT. So that is the investigation that you need to do it. Why? We want to look for any hematological abnormality. So you do a 20 minutes WBCT. How frequently you need to do this?
6 hours.
Every 6 hours is ideal. But if you are able to do it like within first 3 to 4 hours, repeat the test. Initially, if it was negative, you can repeat it another 3 to 4 hours initially, maybe later on 6 hours. But when you have a test called as PTNR, which is much more superior to that, you can do it much more frequently, like every 4 hours, and see the PTNR. Normal PTNR is 1.2. If it is getting elevated above that, then you can start anti-snake venom. So, indications for your anti-snake venom, one of the indications is local envenomation, rapidly increasing swelling, or you have lymphadenopathy, or you have any systemic manifestations like bleeding manifestation, or you have neurological manifestation, or else you should have laboratory abnormalities consistent with coagulopathy. So that is the time when you start, okay, this patient require an anti-snake venom. So you have seen how the anti-snake venom is prepared. You have seen that session, no? So the reaction, how to get adrenaline, how you should manage anaphylaxis and all those things. So depending upon how the patient is responding, you will decide next whether what is the most important thing for this patient. He should be inside the hospital for the next minimum 24 hours. Minimum is what I am telling you. But ideally, when you look into the old evidences, whatever envenomation that has happened, it will happen within the first 24 hours. The initial 4 to 6 hours is the crucial one, but whatever is to happen, that can happen within 24 hours. But there has been case instances, the patient had envenomation after 1 week, 2 weeks, 3 weeks also. They will come with renal failure, unknown cause of renal failure. They had some bite 2 weeks back. Now they are coming with renal failure. That is also a possibility. But you can't keep a patient for how long in a hospital? 2 weeks, 3 weeks. At least 24 hours you are keeping, then you are legally also safe. That is the recommendation from the government of India. Minimum 24 hours of observation. The patient is not ready for observation, we can't help it. But minimum 24 hours of observation is what you need to recommend for a patient with snake envenomation. So that is clear in the first case. So we had a challenge with the tourniquet and we have covered how to deal with the tourniquet challenge in this. Okay. Next case, we have a 34-year-old female. Alleged history of snake envenomation 3 years back, was taken to a nearby hospital. ASP was not available. Referred to your center. Patient complains of abdominal pain and double vision since last 30 minutes. On initial examination, airway patent, respiratory 20 per minute, SpO2 90% of room air, single breath count 20, circulation heart rate of 130 per minute, BP of 100 by 60, Jesus of 15 by 50. So what are the key things that you wanted to get in from this patient? One is abdominal pain. I said abdominal pain is one of the most important initial symptoms by which the patient will complain of envenomation. So abdominal pain and double vision, diplopia. So two crucial things. And what are the other problems? You see the saturation 90%. It is not great. So it should be about 95%. It is 90% now. SpO2 90% on room air, single breath count of 20. So single breath count of 20 is also not great. So you have some respiratory failure, you have some neurological manifestation as evident by diplopia. Now let's see the pictures here. So what you are able to see here, ptosis. You are able to see the ptosis here, the drooping of the eyelids, and you see the swelling here, a gross swelling, and with the whole edema, edematous, and you are able to see some redness here. So that is the bite side. So what would be the culprit?
Great.
Never great. Okay, it can be cobra. There is local envenomation with neurological manifestation. But I am telling you, his WBCT also positive. And it is Russell's factor. So you have neurotoxic with hemotoxic envenomation. Very common to have this in Russell's viper, and most common, the deadliest one what you see is the WRST, Russell's viper. So mortality everything is very high with the WRST. So Russell's viper. So what do you need to do now? To this, how much dose of ASP you want to start?
10
vials.
Why not 5 vials? Why 10 vials?
Because
Why not 20 vials?
Russell's viper injects 60.
It is approximately 63 mg is what from one bite average it will inject. So 63 mg to neutralize that we just need 10 vials. Maximum it will inject is around 150. So to neutralize that we might require 25 to 30 vials. So that is the consensus what we have come up with. So you start with 10 vials of ASV. How will you start? There are two methods. You can either dilute it in normal saline and you can give us an infusion over 1 to 2 hours, or else you can IV push method. So these are the two methods by which you can give ASV. Test dose? No test dose. Why no test dose? This compound mediated. Even if you develop allergy, you don't have any other option. You have to give ASV. There is only one area where we are learning against our learning for anaphylaxis. So what is the first thing in anaphylaxis? Stop the allergy. Here we can't stop the allergy. We have to continue the allergy. because that is the only option to save the patient. So you start on an ISV. Then when will you repeat the blood investigations? After initiating, after 6 hours.
6 hours.
Because you are giving some time for the liver to reproduce the factors. So then only you should you should be testing for your PTN or WBCT, whatever it is. Then the next question should come in your mind: when you should repeat the anti-snake venom?
If
When?
After
After 6 hours, there is hematological abnormalities, or you want to wait for 6 hours. No, the patient is clinically deteriorating. There is still doses, there is still neurological weakness, there is still bleeding manifestation. Even after initial administration of 10 vials, you need not wait for 6 hours. You can give another 10 to 20 vials of ASV. But remember that what the maximum dose what you want to give is 30 vials. Don't go beyond 30 vials. Understood? So when to repeat the ASV to be repeated either 6 hours if there is any hematological abnormalities, or else if the patient is clinically deteriorating at any point of time after your initial dose of ASV, as evidenced by bleeding manifestation or any neurological weakness, you need not wait for 6 hours. You can repeat another 10 to 20 vials of your anti-snake venom. So that is your second case. You understood clearly? Case 3, an 18-year-old boy, no comorbidities, since early morning, unable to speak, unable to open his eyes and walk. So that is a complaint by the mother. So the child was taken to a local hospital. So were they suspected? Probably the child is having some acute flaccid paralysis, bilateral sudden lower limb weakness. On examination, so he was referred from another hospital. These are all real cases what we have encountered. Okay. So this was somewhere around 2010. This patient has come to us. So 2010 he came into our ED. So this was the situation. Airway was not patent. There is a lot of cooling of secretion, but he is moving in and around his bed. He is unable to speak. So there is bilateral crepitation, heart rate of 120 and BP of 130/80, and saturation is only 80% on room air, and respiratory rate is on the lower side. So he was going for an impending respiratory failure. We couldn't assess SPC because he couldn't do anything, because he's unable to talk, unable to move anything, because he's just moving his head here in the bed and he's unable to communicate to us. So what we did, we immediately intubated the patient, put him on a mechanical ventilator. That's the first thing what we need to do. We need to secure the airway of the patient. So what we have done, and we have taken a detailed history. So detailed history, that is the time when I realized that history taking has got such a huge value. So I never realized that history taking is important until I found out this. So this was the differential diagnosis given in the referral letter. I didn't have any differential diagnosis. Don't overestimate me. I never had any differential diagnosis during that time. There was a list. The referral doctor have written down this as the differential diagnosis. Whether it is a Guillain-Barré syndrome, tick paralysis, neurotoxic snake bite, neurotoxic and hypokalemic periodic paralysis. So we asked this history again and again, and I always had my thesis was on snake bite. Okay, so I always had an interest that probably it can be snake bite. That was there in my mind. So we just go and check in and around your surrounding whether there is any snake. For the purpose of the presentation, we just said, okay, just go and see, and this is what they have found out in this house beneath this bed. So the question here is a neurotoxic envenomation, no fang marks, no local reactions, acute flaccid paralysis. So it was a crate envenomation. We gave him ASV after this. So we never knew that it is a snake bite initially. But later on they said they got the snake, then okay, understood. Now fine. We will start treating, because that time there was no WhatsApp and all. So they went there and brought the snake in a cover. Doctor, this is the snake they showed us. Okay, now I understood. Fine, we started the treatment and great. So how many vials you need to start in here? 10 to 20 vials, maybe 15 to 20 vials. You need a little bit go up on this. But again, it is not sufficient. So what is the difference between Elapidae? Viper, you have Viperidae family, we have discussed. Elapidae, you have two. You have crate, common crate and cobra. So what is the venom difference of these two things? One is presynaptic neurotoxin, which reversibly binds. Other one is a postsynaptic neurotoxin, which irreversibly binds. So crate, it irreversibly binds. So you need to give your anti-snake venom. But in cobra bite, when you secure the airway, it is reversibly binding. Maybe within 3 to 4 days, slowly the the receptors, the venom will start getting degraded. But I am not saying that you need not give anti-snake venom in cobra bite. Even if you don't have anti-snake venom, cobra bite can be managed with mechanical ventilation. Respiratory paralysis you manage, the patient might come out after 3 to 4 days. But in crate, you can't do that because it damages the neuroreceptors and it causes irreversible binding. So we need to give anti-snake venom for sure. So whenever you have such a dilemma, whether you have got a snake here, so it's very clear it was a snake bite. Suppose you don't get any snake, suppose you wanted to confirm the diagnosis. What you can do, one thing is you can give neostigmine, a small dose of neostigmine, and you pre-treat the patient with atropine. You give an atropine and give neostigmine and see how the patient is responding. The doses is improving, the single blood count is improving. That gives you a clue. Okay, am I dealing with a neurotoxic envenomation? The patient will improve in myasthenia also. I am not saying it will only happen in neurotoxic, but whenever you don't have a history very clear, GBS, you have some previous history of fever, some upper respiratory infection, and the patient have deteriorated. Myasthenia gravis is a classical history. By evening, the patient is not well. Morning, she will be alright. But here, the symptoms have started in the morning. So, that difference is whenever you have dilemma, you can try this thing and even you can treat with neostigmine and atropine. So, that is the additional treatment that is required in this case. So, we have another syndrome, no local reaction, the patient came with acute flaccid paralysis. So, just at the end of your career, whenever you are practicing, just keep in your mind acute flaccid paralysis in India, we are practicing great innovation without any neurological manifestation. Remember this. The boy never had any local reaction except for some edema over the face, which we are not sure why it has happened. Maybe due to the bite site can be here or somewhere else, but there was no much of an edema. So that is regarding your great innovation. The final clinical scenario, we have again a 44-year-old male, alleged by 24 hours back. So snake identified, they have identified the snake. So I will show you what is the snake. Complaints of minimal pain at the bite site and decreased urine output. That is only his complaint. Since last 24 hours, he started feeling that there is some decrease in urine output and there is some pain at the bite site. He is otherwise airway, breathing, circulation, everything is stable. So you are able to see the 5 marks here. And this is a snake what they are identified. What is that snake? Humulus pit viper. So Humulus pit viper got to be done. Any role for your polyvalent anti-snake venom? No role for your polyvalent anti-snake venom. So that is the message that I wanted to give you. So polyvalent anti-snake venom is not effective against your Humulus pit viper. Suppose you don't have this picture here. You don't have this picture. You are justified in giving your anti-snake venom. But sometimes you are confirmed, okay, it is Humulus pit viper. You are very sure it is Humulus pit viper which has bitten the patient. There is no point in giving your anti-snake. So you are giving, which is going to be futile. So what they can have, renal failure and maybe minimal viability. It will not be INR, will not be like 3, 3.5, 4 and all. What will happen in Resuscitation viper and soft scale viper? The INR will become no clot detectable. The blood will never clot. The blood will never clot. So this Humulus pit viper, maybe it will be just like 1.3, 1.5, 2 and all will be the maximum coagulability. And you will be able to recognize it by the look of it. The classical Humulus pit viper. So that are the 4 case scenarios that what we have. If you have any doubts, you can ask.
So is there any other snake that causes renal failure?
There can be pit vipers. There are 4 to 5 types of pit vipers. It is Malayan pit vipers are there. Malabar pit viper is there. In the big 4, renal failure, yes, soft scale will cause, Resuscitation viper will cause in big 4, but they will also cause coagulopathy. They will also cause significant coagulopathy.
So then why can't we like rule it out like that? That if there is significant coagulopathy with renal failure, then you can start ASV, and then if there is not enough, if there is not significant coagulopathy with renal failure, then you don't need to start because then it might.
How can that be true? A Resuscitation viper can have minimal renal failure. It can cause severe coagulopathy. It can cause severe coagulopathy, severe renal failure. All this can happen for Resuscitation viper also.
No. I'm saying for if the patient has significant renal failure with insignificant or very little rise in INR.
It will happen for soft scale also. They can have similar presentation. Soft scale viper also can have similar presentation. They can just go, see, this renal failure that is happening here is something called as acute tubular necrosis. So, acute tubular necrosis, we cannot predict how much renal failure that you are going to develop. So, from one person will have significant renal failure. This fellow, maybe renal failure will be just 2 created right now. Maybe later on it will start increasing, 4, 5. But the problem is here, when you are knowing that it is unhospitable, okay, we can deny ASP. But we are not very sure whether to give ASP. In the court of law, you will be asked, why did you give ASP for this patient? When I am having this picture and showing this is the snake that is written in, which is not covered by ASP, I don't want to start an anti-snake venom. But otherwise, if you don't have this picture here, and I am not justifiable to him not giving anti-snake venom, I need to give anti-snake venom for him. I need to give him. So I am not sure whether it is a Russell wiper or soft scale wiper or it can be a nose wiper also. So when will be I come to know after like 10 to 20 years of ASP, there is no much improvement in the patient. Then I can think, okay, it can be a nose wiper. That is only by diagnosis of an exclusion. You have ruled out everything, you have treated everything, and finally the patient is not improving. But when I have a picture of this, okay, you are justifiable in not giving. But the most important thing, snake identification is not very key. Some of the people will not agree with this. Snake identification is not very key because we treat usually doing at the syndrome, but only for this fellow, amniospitalizer, the ASP is going to be futile. So there is a possibility that the patient can go in for anaphylaxis by giving the anesthesia.
Okay. Also, it is just mild local reaction.
Mild local reaction, anyway, we don't treat them no, with ASP. Mild local reaction, no lymphadenopathy, just a minimal swelling. I will not give anti-stigma. Anyway, I will not give anti-stigma. So, local reaction, what you need to remember is that rapidly increasing swelling, lymphadenopathy, blister formation, bleeding, then that is significant. You need to give ASP. Very mild local reaction, only pain at the bite side, very minimal. No need to give anti-stigma. If you don't have any coagulation or abnormalities, if you have coagulation or abnormality, yes, you need to give. But if you don't have any, no need to give anti-stigma. Okay, clear? Okay, fine. Any doubts? Any more doubts? No. It was useful for you?
Yes, sir.
Whole day?
Yes, sir.
Interesting?
Yes, sir.
Okay. Fine. Thank you.
Thank you, sir.